I'd like to thank you all for coming today and listening to this little dissertation on joint replacement surgery. My name is Dr. Cohen, and I work at a Memorial Hospital performing hip and knee replacement surgery primarily. I don't know if we can dim the lights a little bit. Is that fair to do that? Can you see the screen okay? So my job is to keep people active. Not necessarily as active as this gentleman who was in the Olympics, ski jumping at the 2010 Winter Olympics up in Whistler, Canada. But my job is to keep people as active as they want to be. And so that's why we're here today, basically to learn more about joint replacement surgery, which can have a huge impact on people's lives and keeping people active. So today we'll talk about several things: how your knee works and why it hurts, knee replacement basics, what patients have to say, and then at the end we'll have a time for going over some questions. And I brought some models in of joint replacements as well, so we can look at those and I can show you firsthand what it looks like. So again, that's my name. Orthopaedic Specialists is the group I'm with up on the 3rd floor in the office building above the eye clinic. So talking about the knee, which is what we're basically here to learn about, it's the largest joint in the body. And people think of it as a hinge joint because it does bend and straighten, but it also rotates. Most people don't understand that, and I'll show you on the model that we use for joint replacement surgery how that can have an effect on joint replacement. So again, basically a hinge that bends and straightens, everybody understands that, but also a little bit of rotation and motion between the two bones. It's made up mainly of the shin bone below, the thigh bone above, and then the kneecap in the front. Many people have arthritis in the knee. The most common form is osteoarthritis, which is basically just the wearing out of the knee. As we get older, as we keep on doing the things that we do, the joint has a tendency to wear out just because of activity. If we walked on our hands, our knees would not develop arthritis. But basically because we walk on our feet, that's what happens over the course of time to a high percentage of people. So most people talk about osteoarthritis, but then there are other types of arthritis as well. Another common one you've heard of is rheumatoid arthritis. It's a large issue as well, but certainly very different from osteoarthritis. It's an inflammatory problem. The joint becomes inflamed, and the tissues wear away from that, basically on the surfaces of the joint. So a healthy knee is covered with what we call cartilage. When you go to a doctor and he talks about cartilage, there's two basic cartilages you hear about. When you hear somebody say, I have a torn cartilage in my knee, they're referring not to the surface coating over the bones, but they're basically talking about the cushion pads between the bones. The medical term for that truly is called meniscus. So the surfaces of the bones are covered with what's called articular cartilage. That's the white, shiny surface that covers over the bones. And when that wears away and leaves bone exposed below, that's what osteoarthritis basically is. So it's a wear and tear, deteriorating of the surface coating over the bones. And that's what causes pain and swelling in the knee. So I guess everybody says, well, how much does my knee hurt? Well, that's a very individual question. And so it really depends on the individual as to how they respond to that. Does your knee hurt 1 or more days per week? Does the pain interfere with your sleep? Is it painful to walk more than a block? Do you take pain medications that no longer work, even over-the-counter medicines or prescription medicines? And is knee pain limiting your participation in activities? Does it stop you from doing what you basically want to do? And because of the knee pain, has it stopped you from being able to be active, and therefore have you gained weight because of that? People can rate their pain. There's different rating scales, typically between 1 and 10, or typically just 1 to 5. 1 being very little or no pain, all the way up to the extreme of 5 being excruciating, debilitating pain, where again you can't do things. Even getting out of chair is difficult, getting off a commode, going up and down stairs, out of a bathtub, all those things cause significant pain and interfere with what you need to do on a day-to-day basis. You can assess your pain by what you're capable of doing. Can you walk? Can you bend over the hips and knees? You can sit in a chair and pretend to drive. There's even something as easy as just bending your knee while you're sitting down to try to go from the brake to the accelerator. Does that cause a lot of pain? Or even golfing type activities or rotation activities, when you try to do such a thing, does that cause a lot of knee pain? Those are things you can easily test yourself to see how much pain you're having. There's all different ways of being able to treat arthritis in the knee, and certainly surgery is the last resort. So we do everything short of surgery to try to get pain relief. There's everything from water therapy. People can use ice packs on their knee. Sometimes people respond to heat versus cold. If you have a lot of swelling, most people would preferable to use ice. Exercise and physical therapy can also be very beneficial to keep the knee mobile and keep the muscles around the knee very functional so they work well. There's medications you can take, everything from over-the-counter medicines. People obviously know about Tylenol, Aleve, Advil. Those can all be very beneficial. Then there's prescription medications, anti-inflammatory medications you can use. And then there are injections when you go to the doctor, everything from cortisone injections to lubricating injections if the arthritis is not too severe. When it comes to knee replacement, again, that's a decision that's basically made by the physician, but more with the patient. And I saw a gentleman today who's 89 years of age. He comes in, he's got terrible arthritis in his knees. The x-rays look absolutely awful, and he basically fits the criteria for knee replacement surgery. But he's sitting there and he says, I can do everything I want to do. It doesn't stop me from being active. I can put up with the pain, and therefore I don't even want an injection. I just want you to x-ray my knees and take a look at them. So he's a candidate not to have surgery, basically because he's basically putting up with his knee arthritis. So when it comes to a point where a patient makes the decision that their knee pain is bad enough to have arthritis and have surgery, that's the most important feature for a doctor to make that decision. So what the knee replacement does is it replaces the damaged surfaces. We basically remove the arthritis and put new coatings on the ends of the bones. Years ago, they used to remove large segments of bone to be able to accomplish this, but nowadays, and we'll get into this a little bit further, we basically just remove the arthritic surfaces and put covers over top. It helps immediately to relieve the pain, and along with a lot of physical therapy, can restore mobility and activity. It's a very common operation, done very, very frequently across the world. And as in this slide, it shows 580,000 knee replacements are performed every year in the United States. So if you have arthritis in the knee and need joint replacement, you're certainly not alone. And the longevity of these implants is extremely good. They've done all kinds of studies. There's just a simple study that showed after 10 years, 99.6% patients still depend on their knee replacement. And that's a very, very good outcome. And there are approximately 8 major companies that make the majority of these knee replacements. And they're all different shapes and sizes, and we'll talk about that a bit more in the future as well. But basically, it shows on the end of the thigh bone, this component that will cover over that. On the top of the shin bone, there's a metal component that covers over that. And between the two, there's a piece of plastic that goes in between that allows a very nice smooth surface for one surface to glide on the other. The femoral component, again, the thigh component, the tibial component down below, and the plastic that goes between the two. So again, you basically cover up those implants, the femoral component covering over the end of the thigh bone, the tibial component, and then the polyethylene or the plastic insert that comes in various sizes to be able to make up for the alignment and the stability of the knee. Most people resurface the back of the kneecap. So you keep your own kneecap. Everybody asks you to take the kneecap away. You don't. You keep the kneecap, but you put a piece of plastic behind it so it glides up and down on the end of the thigh bone very smoothly as well. On an x-ray, that's what a normal knee looks like on the left. So there's the thigh bone above, the shin bone down below, and a nice even space between the two. We get very concerned when you lose that space, and you hear people talk about, I have bone-on-bone arthritis. When they say that, they're basically referring to an x-ray which basically shows absence of this space, and the thigh bone is sitting right down on top of the shin bone, and all the surface coating between the two is gone, and the cartilage pads, or menisci, have worn out as well. So that's what a normal knee looks like, and that's what a knee replacement looks like. Again, the components that cover over the end of the thigh bone, the top of the shin bone. You can't see the plastic that goes between the two, but you can certainly see the space is equal on both sides, that covers the interface between the two. So again, there are many components available. The components that I use is made by a company, a Johnson & Johnson company called DePuy, and the knee that they've developed over the course of years that has an extremely long track record is called the Sigma knee. It comes in all kinds of shapes and sizes and materials, and again, the surgeon makes the decision as to which kind of knee you're going to have, and basically I use the Sigma knee, but it comes in various formats. We'll talk a bit more about that in a second. Again, long-term review of these knees has shown that it's lasted for many, many years, and I have some people that are up to 20 years now that are not having any issues. They come back once a year for an x-ray and they're doing just fine. So it comes in two main types. One's called a fixed bearing, and when I say fixed bearing, basically this plastic is lodged right into this tibial component. It doesn't move at all. And so the femoral component over the end of the thigh bone glides against this very smooth surface. There's no rotation between the two except flexion and extension. This does not rotate other than that. But again, long term, it's shown very, very beneficial, has a long track record, and for certain individuals, and you make that decision at the time of before surgery as to what that patient's going to get, this does very, very well. Again, it shows the different components. The femoral component goes over the end of the thigh bone, top of the shin bone, plastic that goes in between the two, and this is fixed into this metal tray. The rotating platform is a little bit different, basically the same concept, except the plastic rotates inside this, and we have an example of it here. I brought one so we can look at it after the meeting today, and I can show you exactly how that works. So not only do the surfaces flex and extend like a hinge, but also this rotates inside as well. And for people that are extremely active, people that play golf, people that do all kinds of sports, the feeling is that this actually reproduces the knee function a bit better and allows them to do those types of activities a little bit better. Again, here's a study that goes 20 years, 97% of these patients are doing just fine. That's a phenomenal result. Now, the latest generation of surgeries now is not so much the components, it's basically how the components are put in. And all these knees last if they're put in properly. You can have an excellent component, and if it's not put in properly, it won't last very long. So the key to this whole thing at this stage of the game, and for a long time, but even more so now, is to make sure that when you put these components in, they're put in so accurately that everything is balanced. And by that I mean that the knee is straight, the knee flexes and extends very easily, and there's no issues with the ligaments being abnormally tight on one side of the knee or the other. That would cause perhaps progressive wear on one side of the knee more than the other. So this company has developed this system called True Match, and this is really phenomenal. What we do nowadays is when you come to the office and get examined and decide to have surgery, we send you down for a CAT scan. A CAT scan is a very, very fancy type of x-ray which takes basically a three-dimensional view of any joint or extremity. So a 3D CAT scan is taken of the knee and the hip and the ankle because all of it's important to be able to line up one against the other. The CAT scan is then sent up to the DePuy company. They then, on a computer, review that CAT scan and basically analyze it. They then send all that information down to me on a computer disk, and we look at it and we decide where we're going to put the knee exactly. I then approve that, send it back up to the company, and the company then makes a mold of your knee. It only fits your knee, nobody else. It's exactly to the contours and the anatomy of your knee. So when we do the operation, we basically open up the knee, we put these molds on the knee, and I've got examples of these over here as well that I can show you. And so when we make the cuts through the bone, it's so precise and accurate that when you put the components on, they fit perfectly onto the bone. And everything in the leg is completely lined up from the hip to the knee to the ankle, so that when you walk and move on that leg, it feels much like a natural knee. So again, it's accuracy that's the most important thing to be able to get a good outcome. And so True Match is the protocol that we use for that now. So again, it helps the surgeon to achieve consistency in placement and positioning of the knee components. It's a precise fit of the implant on the bone. It reduces pain and restores their mobility very quickly. And it also reduces the number of steps in doing the operation. And basically, it shaves off about a half an hour from the operation because all the decision making on where that knee is going to go is done before you even reach the operating room, as opposed to the old-fashioned way where you have to come to the operating room and during the operation the surgeon makes decisions, and this basically takes that out of the equation. So it really dramatically improves the accuracy. So again, a CT scan is taken, 3D model of the knee is developed. It then allows the surgeon to put these molds on the knee, and again, I've got them here to show you, but basically this is what they look like. They go onto the knee joint on the end of the thigh bone and the top of the shin bone, so that when you remove the arthritis, you simply just remove the arthritis in a very accurate way. Let me go back to this. So if you don't need to have a complete knee replacement, if only one part of the knee is affected with arthritis, there's the option of doing a partial knee replacement. And again, I have an example of that over on the table as well. It's basically the same concept as the total knee replacement, but only a small part of the knee is replaced. So this is an example where somebody has arthritis just on one side of the knee, and all you do is replace the inside part of the knee joint, as opposed to a total knee joint down below where the whole joint is replaced. Again, example here where there's arthritis just on one side of the knee, and you go ahead and just cover up that one part of the knee with that implant. A little faster operation than one would expect because you're only replacing a part of the knee joint. The recovery is a little bit faster as well. And again, same materials are used, the metal and the plastic, that you would with a total knee replacement. Again, potential advantages of a partial knee. Again, you only replace the part that's broken, a little faster recovery, smaller incision, so there's less discomfort, less blood loss as well, and obviously less scarring because you're only opening up a small part of the knee. A lot of people come to the office and they've read all kinds of things about women having to have a different type of knee. And although women certainly have their fair share of arthritis, and perhaps even more women than men have arthritic changes that need to have joint replacement, there's been a lot of controversy about whether they need to have a special knee for their size. That was all developed because there was one major orthopedic company who, when they developed their knees, basically oversized their components. And they didn't fit knees of women very well. But that was only one company. So they developed a separate line of implants that they said it was just for women. But basically it was done so that they would have components that would fit men and women. All the major companies now, all the components are basically sized for that individual, whether it's a man or a woman. They've done lots of studies, and so there really isn't any indication for a woman's knee, because DePuy, the company that I use, has components on their shelf that would fit a woman, or for a smaller size, or a larger size that would fit a man. So that's pretty much been put to rest about having women's knees specifically. So again, as I said down here, current knee replacements are designed to fit anatomies of both women and men. So again, this gender-specific implants for women, again, that's not very important at this stage of the game. Any surgeon that's going to be putting knee replacements in has the option of any implant that they need that will fit the size of that individual, whether it's a man or a woman. Interesting enough, they've done studies and it says 60% of knee replacements have been implanted in women, so more women than men get knee replacements. And again, 90 to 95% satisfaction rate with their surgery. People also hear about minimally invasive surgery, smaller incisions. Clearly that's the wave of the future, to try and do things with smaller incisions. But I think what it boils down to is you need to make the incision long enough to be able to see what you need to see and do what you have to do. So again, it's still a relatively new concept. When I do my surgery, I try to make as small an incision as possible. A lot of it depends on the size of the person and how big their anatomy is. So a hefty guy who's 6'5", weighs 300 pounds is obviously going to get a larger incision on his knee than a lady who's 5'2", weighs 130 pounds. Again, the key thing is to put the knee in properly so the alignment is exact, so that gives you a long-term outlook that's good. Again, less blood loss, shorter hospital stays, potential for faster recovery. Most of my patients, when they come in for knee replacement surgery, stay in hospital typically 2 days, rarely 3. Occasionally we'll get somebody who's really bold and will want to go out the day after surgery. The crazy thing is, this is kind of interesting, the government, because they pay for a lot of these through Medicare, have mandated typically 3.54 days for people to stay in hospital, typical of the government. And so the crazy thing is, if I discharge somebody after 2 days and I don't keep them in for 3.54 days, the government has an opportunity to come back to the hospital and dock the hospital for my releasing them too soon. In other words, the hospital gets a special, what they call a DRG, a certain amount of money allotted for a knee replacement. And so the crazy thing is, if you do a good job and get patients out faster, which you think the government would applaud you for, they actually penalize you for. But I guess that's not surprising nowadays. Another thing you've heard about perhaps before is computer-assisted surgery, and we've done all that as well. So a long time ago, when they first did knee replacement surgery, it was the old concept of opening up the knee, and then you'd put special little guides on the knee to be able to align the components, and hopefully when you put them in, they were okay. They looked all right and they were straight. Then they went to computer surgery, where we actually put computer probes on the leg, and the computer helped to guide the operation. And it does an extremely good job, but it takes added time to be able to hook the computer up and to what we call morph the knee. So you actually have to take a model of the knee during the operation. But it does a phenomenal job, and it's still indicated for people that have significant deformities of their knee, or if they have a lot of hardware around the leg, if they have plates and screws from previous surgery or rods from previous surgery. It allows us to make sure when we put the knee in that it's done very accurately. But now with this true match that we just talked about earlier today with the CAT scan that's done beforehand, it allows us to bypass this step. So again, the benefits of the computer-assisted surgery, again, allows us to visualize the knee without actually having to make large incisions, making sure that the implant goes in extremely accurately. It's kind of interesting, when you do the surgery, you have this big, huge camera sitting in here that's focused down. It looks like something out of E.T., but it's focusing down on the person's knee. And then we have these little inserts on the femur and the tibia that this camera focuses on. And there's a computer during the operation that allows us to monitor how things are going and what we're doing. So again, this scans down to the knee, gives information to the computer, and then we go ahead and put the knee in placement. Again, important safety information. With any medical treatment, individual results can vary, but nowadays it's pretty consistent. Performance of joint replacement depends on your age, your weight, your activity level, and other factors. One of the most important factors is your enthusiasm. Half the battle is the operation. The other half the battle, if you talk to people that have had the operation done, would say that it all depends on how they did with their physical therapy. And physical therapy is really, really important to be able to make sure that that knee works. What we normally do is bring patients in the day of the operation. We do the operation first thing in the morning, hopefully. If we do 3 or 4 in a day, it may not be until mid-afternoon before you get your operation done. If you get it done early enough in the day, you can literally walk on it the same day normally. And physical therapy starts as quickly as possible. And we're very, very aggressive about doing physical therapy to get the knee bending and get people up and walking on it as quickly as possible. There's cooling sleeves we put on the knee to reduce swelling and pain. There's all different kinds of pain medications we can use to keep the pain under control. And nowadays, it's not as big an issue as it was even 5 years ago. So people rehab very, very quickly. And that's really, really important, to be enthusiastic about doing the range of motion and ambulation so that knee works properly. There are always potential risks, and recovery takes time. It's not like going to a dentist and having a tooth pulled. Most people, by the time they return to see me 3 weeks after the surgery, are off their walker and maybe just using a cane. Typically, by about 6 to 8 weeks, they're much more independent. They're going out shopping, going to Walmart. But it really takes probably 3 months to 6 months, and sometimes even up to longer than that, for people to feel like it's their own knee. It takes time to get yourself used to that new knee. One other thing that I'll just sort of broach just really quickly is that if you don't even need to have a complete knee or even a partial knee replacement, then there is an option of doing a resurfacing of the knee. And this is done for people that have a very, very small little area, a dime size or quarter size area of arthritis inside their joint, and they don't need to have the whole knee replaced. So again, the surface coating over the bones that you think about, it should be white, slippery, very smooth and firm. If you look at a fresh chicken leg, for example, at the ball of the chicken leg before you cook it and it turns gray, that pearly white surface that covers over the bone is the articular cartilage. And that's the surface that when it wears away, that's what you call arthritis. So again, the surface coating over your bones should look very much like this billiard ball, white and shiny and smooth. So you have a very smooth surface gliding on a smooth surface. If you look inside a knee and see an area like this, where there's an area where the surface coating is worn off that small little area, but the surface coating around it is okay, then it's possible just to go ahead and cover that one small area. And that's an implant. It's called an arthrosurface. It covers over the end of the thigh bone with this implant here. Again, a small little surface area. And on the tibia bone, a small little white dial goes in there to cover that area as well. Again, so it's less than a partial knee replacement. And that's what it looks like on an x-ray. Again, you can resurface a small little area of the knee on the end of the thigh bone, underneath the kneecap area. Again, it's a nice way of being able to buy more time, especially for people that are in their 40s and 50s that have a small area of arthritis. Again, the recovery is very, very fast. The incision is much smaller, and people get going very quickly on this. So I guess the big question that a lot of people have is, should you wait to replace your knee? Well, again, it all depends on some of the factors we've already talked about today. Do you feel severe pain in your knee? Has the pain and loss of function affected your quality of life? Do you have difficulty sleeping? That's typically what people typically tell me that puts them over the edge. They can deal with it during the daytime, but when they can't get a good night's sleep and they roll over in bed and their knee wakes them up and there's a lot of discomfort and they first get up in the morning and have to stand there before they can get going, that oftentimes is what brings them into the office to say it's time to get it fixed. And also, does medication no longer provide any relief? The key thing is a decision that's made not just by the doctor, but the doctor and the patient, so it's very, very important to have that relationship and have an early diagnosis that can oftentimes help to prevent you from having to go on to joint replacement so quickly. But understand that it's degenerative. As long as you keep on walking on your feet, it's not going to get better typically unless you do something about it, whether it's conservative or surgery, and over the course of time, typically it can get worse. So in summary, the leading cause of our knee arthritis pain is osteoarthritis as opposed to rheumatoid. It's a degenerative problem. It can get worse as time goes on, one would expect. Early diagnosis and treatment for total knee replacements are very important. There's all kinds of studies that have shown an excellent response rate to the surgery, 90 to 95%. That's a pretty high rate of success for surgery. And again, the knee that I use, the Sigma knee, comes in a wide range of shapes and sizes and materials, and we have a very good track record with that knee.